Okay, welcome to another CIMG Facebook Live. I'm Dr. Paul Pomilla. Today we'll be talking about coronaviruses and the COVID-19 epidemic. We are delighted to have with us today Dr. Polsky, who is the Health Director of the Coward County Health Department. And thank you for coming.
Pleasure being here.
Thank you. So I also want to thank our producers, Andrew and Tyler, who put together not only this Facebook Live, but all of the Facebook Lives we've done. And in fact, it was their idea several months ago that this would be a good way for us to communicate with our patients and the community, and it's turned out to be an excellent idea. A couple of caveats before we get started about talking about this COVID-19 epidemic. First of all, it's a rapidly changing situation. So I am going to do my best to give factual information, but what I say today may not be true tomorrow or in the near future. So please keep that in mind. Furthermore, I'm going to ask Dr. Polsky to help fact check me. So if I go off course a little bit in terms of what I'm saying, please interject and get me on the right track. Mostly I'm going to be talking about factual issues. There may be some areas where I will make some conjectures. I will alert you to when I'm doing that. Final caveat is that any views that I state here are my own views. They don't represent any official viewpoint of anybody else. So let me also now just tell you, I think, how the event is going to proceed. Let me give you a little overview. I'm going to give a very brief history of coronaviruses in general. Then I'm going to give a brief history of the COVID-19 outbreak. Then we'll discuss the latest facts regarding the epidemic, including transmission, how it's transmitted, and where the epidemic is currently. And then we'll maybe do a little bit of a deep dive into the case fatality rate and such, and that may be where I do some conjecture and talk about what I think. And the reason I'm even doing that, I prefer not to conjecture, is that I'm being asked all the time these days by family, friends, everybody, about what I think may happen. So I just want to provide hopefully an informed opinion, but only my own opinion, and I have no ability to see the future any better than anybody else does. So that's my disclaimer there. And then finally, I will finish up with what Coward Internal Medicine is doing in terms of preparedness for the outbreak. Then I'll turn it over to Dr. Polsky, who, again, please, if there are comments while I'm going through these other issues, please interject. But at that point, I'll hand it over to Dr. Polsky about what the health department is doing in terms of preparedness and other issues regarding this that he wants to convey to the community and our patients. And then we'll take questions at the end of that. So without further ado, regarding coronaviruses, so they were discovered in the 1960s. There are a variety of different species, some of which infect primarily humans, some of which infect other animals. And generally they were, the initial ones that were discovered really just caused the common cold. So they would cause some bronchitis, some croup, very low, if any, mortality rate to the coronaviruses. That changed a little bit in 2002 with SARS, which was a novel coronavirus. It's systemic acute respiratory syndrome, I believe, SARS. And it was an outbreak that occurred in China, Hong Kong, and even a mini outbreak in Toronto from somebody who had traveled from China or Hong Kong to Toronto. And it occurred from 2002 to 2004. There have been no cases since 2004. It has disappeared. But while it existed for those 2 years, it had an almost 10% fatality rate, and there were 774 deaths. The second more serious coronavirus that became apparent was 10 years after SARS. In 2012, there was an outbreak of MERS, which is Middle Eastern Respiratory Syndrome, and that also has a high case fatality rate. Fortunately, there have only been 2,000 cases since 2012. There is still an occasional case. All cases of that either have occurred in Saudi Arabia or with somebody with some connection to Saudi Arabia. And it seems that the transmission there is camel to human, so eating camel meat or some other exposure to camels. And there's not really human-to-human transmission, so it doesn't have the concerns that other COVID-19 might have. But it does show that some coronaviruses can be more serious than the original ones that were discovered. Okay, so let me move on and discuss an overview of COVID-19, and I may need to consult my notes here. But just a brief timeline, I think, says it all. So on December 8th, 2019, the first case of pneumonia of unknown etiology in Wuhan City, China, that ultimately later proved to be from COVID-19, sort of case one, occurred on December 8th. That's less than 3 months ago. On December 31st, 2019, China reported to the World Health Organization a cluster of 27 cases of atypical pneumonia. At that point, there were no deaths from it. Just 7 days later, on January 7th, 2020, Chinese scientists had identified the pathogen, the virus that was causing that atypical pneumonia, as a novel coronavirus. To me, that is absolutely astounding achievement of science that it took them just 7 days to do that after they reported it to the World Health Organization. On January 30th, the World Health Organization announced a global alert of public health emergency of international concern. At that time, China had over 7,000 cases, 170 deaths, but outside of China, there were only 82 cases and 0 deaths. On January 31st, the U.S. Health and Human Services declared COVID-19 a public health emergency. And I think they did that more just as a legal maneuver to allow for preparedness to occur. At that point, it certainly was not an emergency in this country, and probably still is not an emergency in this country, although of more and more concern. On February 4th, 2020, the CDC got expedited FDA approval for a test kit. I believe that even prior to that, other countries had test kits that they were testing for this virus. Again, that's sort of astounding, coming from being there at the beginning of the HIV epidemic and knowing it took several years before there was a test for HIV. The speed at which the science is trying to keep up with this epidemic is impressive, I think. So as of yesterday, March 3rd, when I last checked, there were 93,000 cases, more or less, worldwide. 90% of those were in China, 5% roughly were in South Korea, 2% in Italy, 2% in Iran, about 1%, just under 1%, were passengers on the or crew members on the Diamond Princess cruise ship, and 0.01% of cases worldwide are in the U.S. That's 124 cases and 9 deaths as of yesterday. Worldwide, there's been 3,200 deaths. 50,000 of the 93,000 cases have recovered. Now, I believe for somebody to be considered recovered, they have to test negative for the virus. So many of those people who may not be considered recovered yet are recovering, but may not have had a test yet that shows the virus has completely cleared. Okay. Moving on to any comments?
No, you're doing great.
Okay, I'll keep going.
I'm taking notes.
So regarding the transmission of the COVID-19 virus, it seems to be transmitted primarily by droplet, and that's the way the flu is transmitted. So by droplet, it is saliva, and it can land on doorknobs, it can land on banisters and such. And so the best protection from droplets is, first of all, to not be exposed to somebody who's sick. If you are, to be at a distance from them. To wash your hands is really vital. To wash your hands before you eat, but to wash your hands, we're touching things all the time and we don't even realize it. And then we may be touching our face, and certainly if we're eating, then we're touching our mouth. And so hand washing is really of paramount importance. In terms of the transmission rate, go ahead.
If I can just interject for a moment. So people may be wondering, on inanimate surfaces, what can I get infected from and what not. So as you've been saying, that there's still gaps in what we know, but there's a fair amount of what we do understand at this point through a lot of research both within the US and in other countries. And so one thing that we do know is that in fabric like this, we don't see transmission. On hard, non-permeable surfaces, then we can. So for people who are wondering at home or in their children's schools, what should be cleaned, what really doesn't need to be cleaned, fabric does not have to be cleaned on any regular basis, anything other than you would normally do. It's not going to transmit virus, at least not coronavirus. But hard surfaces, as you were mentioning, doorknobs, banisters, maybe the remote control for the TV, those are things that if you know somebody is starting to come down with a little something, it's reasonable certainly to clean once or maybe a few times a day. We've been working with our school system to make sure, and this is all through flu season, so this is, and also keep in mind that we do have an overlap between influenza and coronavirus. So although to this point, as far as we know, there's no coronavirus in Maryland, much less in Calvert County, the things that we're talking about as far as prevention measures are going to be equally effective to minimize the potential for people transmitting influenza, which certainly, unfortunately, kills a lot of people in this country. Estimated about 30,000 people in this country have already died from influenza this season, and we still have at least a month to go. Last year it was over 50,000, and the year before that was particularly bad. There were about 80,000 Americans who died from the flu. So in the schools, as flu season picks up, the schools are automatically doing extra cleaning, and you can take a look on the EPA website, on the health department website to see the kind of products that are approved we know will kill viruses. So in schools, they're cleaning high-touch surfaces at least once a day, and now with the concerns of coronavirus, I think in most cases they're cleaning 2 to 3 times a day. So if you're wondering for your children in schools what sort of measures are being taken, that's one of the things in schools that they're doing.
Very good, thank you. I'm taking notes now. Do you want to talk about any products that are known to?
Well, as a state employee, I'm not allowed to,
Okay.
talk about specifics, but many of them are already labeled. And I think in this case, if you're getting name brand products, taking a look there, that they're probably not going to risk their reputation by falsely advertising. So again, you can check websites to see specifically, and then if you want to get the store brands, which may be cheaper, you can take a look at the active ingredient in the name brand, and then just like what you do maybe for medications, you take a look for a name brand over the counter, and then you may take a look to match it with a generic that might cost half the price.
Very good. Yes, and actually I have done that. I've looked at a cleaner because somebody told me that a very commonly used cleaner, I guess I could say the name, but I'll refrain since I'm not a government employee. But if you look at household cleaners, it will say, kills coronaviruses. Now, they haven't been studied necessarily for COVID-19, but the presumption until proven otherwise is that it would kill COVID-19.
And this is a reasonably fragile virus. The lifespan on most hard surfaces is only about 4 hours, where some viruses will hang out there for days and still potentially be infectious. So this is one of those that's not going to be super resistant. For most cleaners, we find the cheapest way is to do a bleach solution. So if you really want to pinch your pennies, then it's 1 part bleach to 9 parts water. So if you have 10 parts, a tenth of that is bleach, and the rest is water, and you can put it in a little spray bottle and spray it around and wipe off. And that does a great job for cleaning both for coronavirus, for influenza, and for other bacteria and viruses.
Excellent, thank you. Yeah, I was going to mention that viruses live on surfaces generally for 2 to 4 hours. I mean, viruses require living tissue really to propagate, so they don't really survive long in general on surfaces. Very good. So let's talk about the mortality rate and the seriousness of this novel coronavirus, because I think that's top of mind for most people. And our understanding of that is going to change as we have more data. So this is definitely some information that will change. But as of right now, what we're seeing is that about 80% of people who are known to have been infected get mild illness, sometimes asymptomatic illness, no symptoms whatsoever. About 15% get seriously ill, they get a fair amount of symptoms, and only about 5% get critically ill from this. And out of that 5%, about 50% succumb to it. it's pretty clear already that the elderly fatality rate is the highest by far. If you look at the crude mortality rate, it's about 3.4% because there's about 90,000, almost 100,000 cases, and there's been about 3,400 deaths. So that's a pretty high crude mortality rate. And this may be where I get into a little bit of conjecture. So realize that that's what it is. And some experts are talking about 2% mortality rate is being thrown around. I believe that we're going to find that the mortality rate is probably a lot less than that. And I say that for a couple of reasons I like to talk about. First of all, there's case-finding bias. That is, the sickest patients come to medical attention right away, and it may not be apparent that there are a lot of other people who are infected who just aren't that sick or aren't sick at all. And so it's not uncommon when there's a new disease that the worst cases come to attention first. So there's that. And then I think there's two different places. Do you want to say?
And there was a study that I just saw for the first time this morning out of an independent group that was led by a Canadian physician in China, because that initial research out of Wuhan, as you mentioned, showed 3.4% mortality. But as he took a look as the disease process has gone on over the last few weeks or the last month or two, that the mortality rate, even in Wuhan, continues to decline compared to the number of cases. And he said, as you mentioned, that initially the only people getting diagnosed, or most of the people getting diagnosed, were those who were very sick, and that people who had milder symptoms were never getting tested. So you had the number of people who died and not as many people who otherwise were reasonably healthy and then recovered. So the mortality rate, the fatality rate looked worse. The second factor was that initially doctors didn't know what they were dealing with, and they were potentially trying the wrong treatments because they thought they were dealing with a different type of illness or infectious agent, and they really weren't, and it took them weeks to really figure out what the best type of treatment was. So it's possible that if they had known, at the beginning, that maybe some of those people who died initially would not have died.
Mm-hmm.
And then a potential additional factor, which there's no way to really know for certain, is that sometimes when a virus jumps from an animal species to a human, there is some kind of genetic mutation that's going on at that point. And it's possible that during that instability of genetic mutation, that the most severe strains are so lethal that they actually don't propagate, because the people are dying, they're not. A virus ideally doesn't want to kill anybody.
Mm-hmm.
A virus just wants to get from person to person. It's indifferent whether somebody gets sick or, and so the longer that somebody is potentially transmissible, those strains are going to then propagate more. The strains that are quickly lethal are going to fade away. So it's possible that maybe in the very early stages that there were some virus particles out there that were more deadly, and we don't see them anymore. And now by the time that it's made it, halfway around the globe, that we may be dealing with milder or less lethal strains of the virus.
Very good, yes. I'd make two additional points that agree with that. Two pieces of data. So if you look at the Diamond Princess cruise ship, where I believe everybody or nearly everybody was tested, and there were 706 positive patients who were infected, which also tells us something about the transmission. That means 80% of the crew and passengers were not infected, but 706 cases were infected. There have been 6 deaths reported, mainly, I believe, from elderly people. So that gives a case fatality rate in that situation of under 1%. And finally, if you look at South Korea, which has done thus far more testing than anybody else, they've done over 100,000 tests. They're testing a lot of asymptomatic or mildly symptomatic people. Their case fatality rate is 0.5%. And so I think we may ultimately find out that may be high range of where this virus really is. Now, I don't want to trivialize that. 0.5% case fatality rate is quite serious. It's devastating if it's you or your loved one, or if it's me. It could be existential and devastating. But in terms of public health concern, that gives it some perspective. In fact, to give it a little bit more perspective, the seasonal flu is generally thought to have a case mortality rate of about 0.1%. The 1918 Spanish flu epidemic case fatality rate was probably up to 10%, and these are all estimates by experts, but it's impossible to be precise with these types of things. And then the Ebola virus case fatality rate was well above 50%. There are actually now some treatments for Ebola, and it may be much less than that, although still in the 50% or so range. So, in other words, this virus may be more akin to seasonal flu than it certainly would be more akin to Ebola virus, at least in terms of mortality rate.
And we shouldn't paint globally, so that another thing that we certainly have seen is that most people who become severely ill or who have died from the virus have been elderly, generally in their 70s or 80s, or at any age they've had a significant underlying health problem. So we are certainly more concerned, as we are for any virus or any bacterial infection, for people with insulin-dependent diabetes, someone who's just had chemotherapy, for people who've had transplants and maybe on medication that suppress their immune system. And then there are a host of other autoimmune problems where people will take various sorts of medications to keep their underlying disease process in check, but that makes them a little bit more vulnerable. For people who are reasonably young, and it's a relative term, so I would say that for people under age 60 and in reasonably good health, the potential they'll have severe illness is very low with this strain, and that includes children who also don't have underlying health problems. The most important thing to me from a public health standpoint is that even though, let's say, an 8-year-old is unlikely to have serious health problems, or someone in their 20s or 30s, that they can then potentially transmit to others who may be more vulnerable. So the precautions that we'll talk about, although maybe not having so much severe health consequences for that individual, it's important for them also to try to minimize the risk for becoming ill, and then if they should get sick, minimize the potential they may transmit to others, because in someone else it may turn out to be a very serious infection.
Right, and under that heading of immunocompromised people, sometimes people forget, but the biologic agents used to treat arthritis and psoriasis also can often suppress the immune system. So people in those situations have to be particularly careful. Very good. So so again, just in terms of, to finish up this topic and in terms of conjecture, again, because I've been asked this a number of times, I think best case scenario, maybe a 5 or 10% chance of it happening this way, is that quarantine and social isolation, as it's called, removing yourself from people who are sick, if you're sick, removing yourself from others, may ultimately be quite successful, and the transmission rate may go down. We're already seeing some success in China with that. It's possible that other places may not have the success that China is having. And it may sort of burn itself out, sort of like the SARS epidemic did in 2002, 2004. On the other hand, on the other end of the spectrum, maybe a 5% chance is worst case scenario, where it does spread more widely. What prevents that from happening, I think, is that there is so much public focus on this, public education, and that's a great thing. And so people are already being careful, self-isolating. And what's also mitigating against that is just cooperation among countries, a free press, and information out there. But worst case scenario would be that it spreads more and that there's a year or two before there's a vaccine. But I think that's unlikely for it to get to the point where it's spreading like the flu. I just think there's too much public effort, public information out there right now. Worst mitigating factor is what happened in 1918, and not that I think this is on the horizon at all, but if there is complete social disruption because of a world war, it's really the war that made the 1918 flu epidemic as deadly as it was. Some of it was the virus, but a lot of it was social disruption in the war. So as long as countries communicate and keep things open, it's less likely. That's very helpful keeping this under control. So I think the most likely scenario is somewhere in between the best case and the worst case. I think social isolation will help a lot to prevent the spread of this, and In terms of Calvin Internal Medicine's response to this, even before this epidemic, when somebody has respiratory symptoms, they are asked by the receptionist to mask as soon as they enter the office, and masks are available for everybody, and that should be done year-round to prevent the flu or whatever's going around. We are following the CDC guidelines. Those guidelines get updated frequently. We're updating as they go along. So you will be asked when you make an appointment or at the kiosk when you come in, or when you talk to the receptionist, some questions, screening questions about international travel and your symptoms. If you do screen positive, you'll be asked a second set of questions. If there's still then concern, you'll be immediately brought back by a medical assistant to an exam room. A physician will see you promptly. They will evaluate you further. And if there are concerns, then they will notify the emergency room ahead of time. You'll be transported there. I'm not speaking today on behalf of Calvert Health, but I am the medical director of the infection control committee there, and I can tell you that they are very well prepared. They have a excellent, experienced team with infection control and otherwise there, and they are prepared. They have ER exam rooms ready, and they're following CDC protocols themselves, and they are ready for any eventuality. So they're set up for this as well.
Just wanted, if I can make a quick comment about the masks. So, as Dr. Pomilla said, someone who is sick, putting on a mask is appropriate. If I have a respiratory infection and I cough, the droplets that are coming out are relatively large when they first come out of my mouth, and the mask is going to catch those. But as they continue on in the air, they get smaller and smaller, and those particles, so if Dr. Pomilla is with me and I'm sick and he's not, and he has a mask on, those little particles are either going to go right through the mask because they're so tiny, or they're going to go around the little seams here and there. So I know it's been on the news and other places, or if you've checked the website for the health department, you've seen our recommendations that people who are healthy, there's really no benefit to them wearing a mask. It just gives a false sense of protection, and maybe those people might be less likely to take other more important precautions. As we talk about other ways to protect ourselves, protect our family, I think one very important thing is that when somebody is starting to feel sick, stay home from work. Employers, and this, I don't think this gets mentioned enough, employers have a stake in this. That if you have somebody who is starting to develop an illness and they feel compelled to come to work, either because they don't have a leave built up or whatever the situation is, that employer may end up losing half their staff the next week, because if that person ends up getting all their coworkers sick. So as an employer, it's good business practice to tell that person just to go home. If they're well enough that they can do some work from home, that's great, but you don't want to end up losing your staff. And the other is that, for anyone in the retail business, that whether it's restaurants or any kind of business, that if a lot of people get sick in the community, they're not going to be coming out to your business. And so we all have a part to play in preventing the spread of illness. Of course, from a health standpoint, we care most about health and safety of people, but the reality is there's also an economic aspect, and you've mentioned the 1918, 1919 flu a couple times. There were a huge number of businesses that just went out of business because people were just afraid to go out and mix with other people. Restaurants went out of business, theaters went out of business, so a lot of economic disruption happened as well as the health issues.
Okay, thank you for those comments. The last thing I guess I would say is that also telehealth is an option for certain illnesses, and there are places that do that. We have providers that do that, more and more providers who are signing up for that, so that's always an option as well instead of coming to the office. I think that concludes what I want to say. Are there any other comments you want to talk about?
I would just also throw out, so the health department, we work with all of our county partners, including Calvert Internal Medicine, staff over at the hospital, schools, DSS. I particularly want to mention for EMS, for our ambulance crews, that resist the temptation to call for an ambulance for something that you can reasonably get a ride somewhere. That we have, as most people are aware, all volunteer staff, and we have a limited number. So if we do see some increase in illnesses over the next month or so with coronavirus, we don't want our ambulance crews being tied up for situations that are not true emergencies. We want to make sure that if somebody has a heart attack or has a stroke or there's a bad car crash, that those crews are available to treat people who it's truly a matter of life and death for them to get there. So I'm not telling people not to call 911 if there's good need to, but to use some discretion. And if you feel like you need to go to the hospital, but somebody is available to take you in personally to avoid the 911 call.
Excellent point, and I didn't go into detail, but I said that a patient here would be transported, would go to the emergency room, but if they're well enough, they would transport themselves to the emergency room wearing a mask, but we would call it the ER ahead of time so that they'd be prepared for the potential case. Any other comments about the community or?
I think it's important for everyone to understand that the health department and some of our community partners, we plan for infectious disease outbreaks all the time. So this is not something that a month ago, all of a sudden we had to try to figure out what to do. A couple of years ago, we had Zika that we were preparing for, and it was Ebola prior to that, and H1N1 a little while before then. So we have health professionals who specialize in preparing. Again, we work with all our partners. Earlier today at noon, we had a meeting with our EMS staff, with hospital staff, with our schools and DSS. Everybody is set to go. We hope we don't need to put things into play, but as far as supplies that are available, contacts with the CDC, with the State Department of Health, all that happens on a regular basis.
Great. Okay. So are you prepared to take some questions, Dr. Polsky, if there are any? Okay.
All right. We took a few questions before the live, and we also have some that are from our viewers that are currently in the live. First one we'll do with Karen Donnelly asked, would you put off a vacation in Mexico or the Caribbean or any traveling by plane as of now?
All right, you're looking at me. I'll take the first stab at this. It's very, I get asked this a lot lately as well. And it's really hard to put into play all the factors that involve travel, whether it's for pleasure, as I think she's implying, but also there may be other reasons that people want to travel to visit family, maybe family who are sick, etc. And so or people who are studying abroad. So there's so many variables that I can't give great travel advice except to follow, I think, the CDC guidelines. And at this point, they're concerned about travel to 5 countries: China, South Korea, Japan, Italy, and Iran. I don't think that there is concern about travel to other countries.
So I would say the travel during cold and flu season is always a little bit of a roll of the dice.
Mm-hmm.
I wouldn't say I expect to get sick if I travel this time of year, but I realize that's just part of the nature. I think in terms of coronavirus, if somebody meets one of those higher risk categories, then not necessarily strictly for coronavirus, but because of influenza or other types of infections, that maybe to think twice. But if otherwise someone is reasonably healthy, traveling to Mexico, traveling to the Caribbean, I don't see any need to delay travel plans.
Very good. Excellent.
All right. And Kiera asked, are pregnant women more susceptible to catching coronavirus, and what are the risks for the unborn baby?
So that's a really good question, and actually we have some information on that. As far as a baby, there has not been any evidence that of any harm to the baby inside or shortly after birth. We don't have enough information for pregnant women, and I realize I just said that we have information for the babies, so it sounds a little contradictory, but we're talking about a healthy adult versus a fragile infant, so we don't need as much data for fragile infants to feel comfortable as we do for otherwise healthy pregnant women. I will say that in general, pregnant women, and so I guess I should mention I'm an obstetrician.
I was going to mention if you didn't.
So this is my area. That in general, when a woman is pregnant, her immune system is slightly suppressed. And so we think the reason for that is that the baby is genetically half hers and half from the father. That slight suppression of her immune system is to minimize the chances that her immune system would attack the baby as being genetically different. So we know that women in general, if they get sick, and this goes for the flu in particular, but also for lots of other viral illnesses, that they tend to get sicker than a woman of similar age and health. So for the flu, and this is always good advice, that for anyone, they should get the flu vaccine. For pregnant women in particular, we really, really emphasize. So for coronavirus, to this point, the information that's out there has not shown any major health problems for pregnant women, but I would say that it's likely that the severity for a 20-some-year-old who's pregnant is going to be a little bit more than a 20-some-year-old who's not pregnant.
Very good.
And Karen Donnelly asked, would using something like Nosin be effective in prevention?
So Nose I have some experience with because we use it at the hospital to treat bursa infection in the nose. I have not seen anything published about it, and MRSA is a bacteria. This is a virus. It is a fairly fragile virus, as Dr. Polsky said, but I just don't think there's any data out there. I'll be interested now that I've heard this question to look and see, but I'm not aware of any data. Are you aware of any?
I'm not, and that's not going to penetrate down to the lungs. So I would think that it's probably not going to be effective. Nosin, my understanding is that's more for people who are carrying bacteria, and viruses are living inside the cells in a way that bacteria don't.
Right.
So penetration would be a little bit different. So I would say that I would think that in theory, at least, it's unlikely that the Nosin would be successful. And again, there are lots of researchers right now across the world looking for what medications that are current may truly be effective, and then certainly working on new medications that may help. And I will throw in, because you mentioned the SARS back in 2003, that there was a fair amount of research going into vaccines for coronavirus at that point. SARS, as the seasons changed, it dampened out and did not come back, and that research never was continued. Funding was cut off. And so I'll just throw out a little public health that there should have already been a vaccine developed for coronavirus. Mm-hmm. And that's the problem when less than 1% of our healthcare dollars are spent in preventive measures. We spend 99+% of dollars after people get sick in treating them, that as a national policy, we should be devoting a higher percentage. And so in instances like this, that a vaccine gets developed in 2003, we might need to tweak it a little bit, just like we do for influenza each year when the strains are a little bit different, but you have your influenza. So yeah, in 2020 we have no vaccine, and it's likely at least a year away before we would have anything that would likely be safe and effective.
Excellent point.
Sally Brandon asks, how will this affect patients that are with autoimmune disorders?
Yeah, well, I think we've answered that a little bit in part. So if they are immunosuppressed, they are more likely to get sick would be the presumption. And so they have to be even more careful.
Would the flu shot or pneumonia shot be any help with lessening the symptoms?
I don't think that that's going to be relevant to this virus, probably. I will say that if and when a vaccine is developed for coronavirus, there's no reason to expect that one would need to be vaccinated every season. The flu is a little bit unique in its ability to mutate and require a new vaccine. Most viruses, measles, chickenpox, we vaccine once or a series at the beginning, maybe a booster later in life because somebody's immune system has waned, not because the virus has mutated. But if there is a vaccine, I'd expect, the expectation would be there would probably be a one time or just a short series of vaccine for it.
And I will take it off on a slight tangent. That I think for the first time since smallpox was eradicated, the experts at the CDC have actually backtracked and said that there's now a group of people who no longer need to get a vaccine. So, because you mentioned the pneumonia vaccine, so the Prevnar 13, the CDC within the last couple of weeks has said that seniors who are otherwise healthy no longer need to automatically get the vaccine. For those with underlying health problems, they should. And the reason that they don't have to is that a little over a decade ago, that vaccine was started to be given to children as they're part of the routine vaccine series. And the reason for that is that children do get, especially younger children can get pneumonia, but they more importantly can get meningitis from that same bacteria. Well, as that initial group of children stopped getting those infections, they were no longer transmitting it to their grandparents. And so the infection rate in older people became so low that they no longer needed to worry. And the reason I'm bringing up in this context is, again, the importance in daycares and in schools of minimizing transmission, because although the children, again, aside from those with immune system problems, most children are not at high risk, but if they get infected, and kids are virus factories, when a child sneezes, they often will have about 10 times more viral particles in its sneeze than an adult will. So if you can minimize the infections in the pediatric and child population, you dramatically lower the risk for their grandparents, for seniors who really are at the highest risk of serious health complications.
One of several vaccine success stories. I have never seen a case of measles. I know there was a mini outbreak, but I've never in my lifetime seen a case of measles, and it's been well over a decade that I've seen chicken pox. So those are vaccine success stories as well.
Tom Wyckoff asked, he purchased the AirNum 2.0 because, as he understood, it being a KN95 certified makes a difference. If there comes a time when the COVID-19 virus is spreading in our area, will it help with ritual cleaning of the hands with bacterial soap? Will the mask help as well?
In addition to...
Right.
I'll let you...
So I can't speak to any particular brand. So I'm presuming, so the key with that was the N95, which has to do with the pore size in the mask. So when I used to do certain types of surgical procedures, sometimes virus particles would get aerosolized, and I would wear an N95 mask so I didn't breathe in those virus particles. So they are effective, but it gets back to what we talked about before, that in general, for the average person wearing those, it's not really going to change their risk. I think the exception to that is if you have a family member who needs care, and let's say that I was at high risk for serious health complications and I had to care for that family member who was sick. In that case, I would suggest, and maybe for practical purposes because they're feverish, they're not going to be able to wear a mask, that it would, in that instance, it would be a good idea for me as a very susceptible person to then put an N95 mask on when I was in the room with that person. Outside of the room, I don't need to continue to wear the mask.
I'd like to add a couple of comments to that too. I agree with that. So if your risk of infection is 0.0001%, as mine is today in Calvert County, putting on the mask really hardly reduces the risk. That's zero anyway. And yet it may be taking resources away from other facilities, and that's a real issue apparently, as I'm reading, that healthcare facilities are needing masks and having trouble getting it. So it really is a resource problem. And then the second thing is, those in the hospital with those N95 masks, you have to be fit tested for it to make sure you know how to wear it properly. And people who have lung problems, COPD or asthma, are not permitted to wear those, and therefore not permitted to take care of patients where that mask would be needed, because it can interfere with oxygen intake. So it's not trivial to wear an N95 mask. It's not for everybody, for sure.
All right, and the last question that we'll do, Audrey Whelan asked, are there any talks taking place in the health field regarding the longevity of this coronavirus?
I think as Dr. Pomilla had mentioned, it's a bit of speculation. So what we do know is that typically coronaviruses like the flu are seasonal. As we get into warmer months, that we tend to see the virus naturally dissipate. It doesn't like really warm, humid air. And so the expectation, if things follow to suit, is that it's likely into May or June that we'll see the virus naturally go away. I think what's the unknown at this point is because this is newly introduced and we have a large potentially susceptible population, that the virus could transmit a bit longer than what we would see if this was the seasonal flu. And that's something that honestly we won't know until we see what happens over the next couple months.
I have nothing to add to that. Okay, we all set?
Yep.
All right, thank you so much for joining us, and I want to thank Dr. Polsky again for taking time out to join us. Thank
My
you so
pleasure,
much.
and I'll just throw one last thing in because there has been a lot of just complete garbage on social media. I know we're on social media right now, but certainly be mindful. There are things that can sound very plausible, and it's just bad information. And sometimes following that bad information can actually put you or your family at risk. So it's not trivial to just, because it looks good or because 27 people have reposted or retweeted it, it doesn't make it true. And so I would encourage everyone who wants to keep up, you're welcome to come to our website at the Health Department. We also have a Facebook and Twitter account. There are other reputable sources of information. The Health Department website, which is www.calverthealth.org. We also link to the most current CDC and other reputable sources, so you'll not only get local information from us, but you'll also get good sources that are national or international. I've been adding posts at least once a week. Although the media continues to hype this, the reality is that most days there's nothing really new that's important, and we're not posting just for the sake of posting. So anytime important information comes up for residents of Calvert or Southern Maryland, we will make sure that very quickly we have it up on our sites. So whether you directly check our website and we have it on our homepage, or you go to our Facebook or Twitter accounts, you should get up-to-date and accurate information.
Thank you so much again for your great information. I want to thank the audience, and good night.